It's a special honor this morning to introduce our keynote speaker. Dr. Rodney Howell is professor of pediatrics and a member of the I'm out of breath here. Hussman Institute for Human Genomics at the Miller School of Medicine of the University of Miami. He's certified by the American Board of Pediatrics, the American Board of Medical Genetics in the area of clinical biochemical genetics. And in fact, he's received the Lifetime Achievement Award from the Duke University Medical Alumni Association, the Lifetime Achievement Award of the American College of Medical Genetics Foundation, and the Lifetime Achievement Award in Genetics from the March of Dimes. To commemorate the 30th anniversary of the Federal Rare Disease Act, he was named one of the 30 Rare Disease Heroes by the U.S. Food and Drug Administration. In 2015, Dr. Howell was the first recipient of the Advocacy Award from the American Society of Human Genetics for his excellence and achievement in the applications of human genetics. Dr. Howell was the founding chair of the Advisory Committee of the Heritable Disorders of Newborns and Children and the congressionally mandated committee that advises the Secretary of Health and Human Services on issues concerning newborn screening and the recommended Uniform Newborn Screening Panel, or the RUSP. That set the standard for newborn screening in the U.S. Dr. Howell has served as chairman of the Muscular Dystrophy Association Board since 2007, and he was elected president of the International Society of Newborn Screening based in the Netherlands in 2016. He's actually had more honors than this. I remember a particular moment about 10 years ago when I was at the third annual North African Conference on Newborn Screening in Qatar. And one of our colleagues from Germany, Dr. George Hoffman, got up and showed a slide that had an old Daniel Boone type rifleman shooting off into the distance. You couldn't see the target. And George's comment was, "Those Americans, they'll shoot at anything. They're cowboys." And I emailed this immediately to Rod, and he wrote back and said, if it's something to the effect of, if we're empowering treatment of newborns and it'll improve the quality of life of patients, give me a fast horse. So, Rod, thank you so much for joining us today. We're all eager to hear your important message. Thank you for coming.
Thank you. Chet, thank you very much for those very kind words. They must have been written by some very close friend and so forth, etc. And it's certainly my honor. I'm very pleased to be here today, and it's wonderful to have an opportunity to talk with you ever so briefly about newborn screening. I'm going to speak quickly about a variety of subjects, and we're not going to go in any depth in any of these, so you will be perfectly aware of the fact that we're just looking at the surface. I've listed the potential conflicts I have. I'm very actively involved in a variety of companies and federal and foundations that have to do with newborn screening. The first thing I want to do with you this morning is I'm going to spend a fair amount of time about the historical aspects of newborn screening. In other words, the circumstances that required the development of newborn screening. I'm going to spend a goodly bit of time then talking about what's happened to newborn screening and kind of where we are today. I will have very little in the way of biochemical genetics in this, but I'm really focused almost exclusively about policy issues that have driven newborn screening. And then right after me, we'll hear Amy will present a very important thing about where we are with lysosomal disease screening. I like to think of the fact that newborn screening, the situation that mandated newborn screening began in Oslo almost 100 years ago. Harry, a young dentist, and his wife Bjorn Eglund were concerned that their 3-year-old daughter was very slow in speaking, clearly slow. And while dealing with this concern, Bjorn recognized she was pregnant and soon had a boy delivered. His name was Dag, and he also was found to be quite delayed. The Eglunds were aware of a very strange, musty odor, which they thought might be causing the child's retardation. Beginning in the very early days, you can see that observant parents and so forth have been important in newborn screening. The father, who had asthma, was said not to be able to be in the room with the child. They sought the help of a chemistry professor that had taught Harry in dental school, Dr. Ashburn Furling, and he had published a thesis about the mechanism of acidosis, and so they thought that he would be a good person to consult about what this strange odor in their delayed children. Bjorny was asked to bring urine samples to Dr. Furling, and he did a very routine screening test for that time, the ferric chloride test. Back in the old days, rather than the current technology, ferric chloride was added to the urine when you were looking for the presence of excess ketones. And if you had lots of ketones, it turned dark brown. And so he added ferric chloride to the urine, which is a routine thing in the thing. And instead of getting a dark brown color, he got a very distinct green color that was evanescent. Why in the world was this green color there? Was it diet? Was it herbs and so forth? And they eliminated those. And so Furling asked Mrs. Eglin to collect urine, a lot of urine, and bring it to the lab. And she was really a hardworking mother, and she brought 20 liters of urine to the lab. That's probably more than you wanted to see, but anyway, it came. And he used very laborious technology at that time, increasing salt concentrations to these urine in order to precipitate abnormal compounds that might be present. And it was very nice because he was looking for a compound that caused a green color. So as he got precipitates of various and sundry stuff, and he dissolved it in water and added ferric chloride if it wasn't green. But eventually he got a precipitate that when he dissolved it was green. And he further identified that as phenylpruvic acid, and he saw that that was a striking compound in both these kids' urine. And so he called these children as having phenylpruvic oligophrenia, which was the previous name for what we call phenylketonuria. He wondered whether or not this was a feature of mental retardation, developmental delay, and so he went to a series of facilities around Oslo and tested 400 plus children using urinary ferric chloride test and found 8 within this institution. And his original paper that was published less than a year after the Eglins first brought their kid there had 8 patients that were categorized in there. Now, this is the color. Many of you have never seen a ferric chloride, and hopefully you will not see an untreated patient with phenylketonuria. But on your left, there's a urine sample that's had ferric chloride added. Ferric chloride is a brownish color, and then the right is a transient green color. It's very specific and is short-lived. It was perfectly clear that the problem in this patient was the marked elevation of phenylpruvic acid, as you can see here. They identified quite promptly that phenylalanine was elevated and that phenylalanine was not being converted to tyrosine, and this was lacking an enzyme here, phenylalanine hydroxylase. I might point out phenylacetylglutamine is also present in these urines, and this is the material that causes the musty odor that we talk about. Now, it was perfectly clear that if indeed phenylalanine accumulation in the body was the cause of the condition, it's an essential amino acid. So it's perfectly clear that if that indeed was causative, if you reduce phenylalanine in the diet, you should be able to reduce it in the patient. And this was clear from day one. However, at that time, the war was raging in Europe, and so not much happened at that time with the diet. Now, I might point out however, there was a great interest in looking broadly in institutions, and quite promptly, over 400 patients were identified who had positive ferric chlorides in the urine, and they were all at that time in institutions. They were not being treated, obviously, and this is a plot of the intellectual ability of those children. I might point out that the average ability of these children is under 20 when they're institutionalized and untreated. This is kind of interesting. From day one, it was perfectly clear there were always a handful of people that had only modest delay, and we're not going to talk about that, but that was our now. So the war ended, and interest in science flourished. And Bickel, who was a German scientist, was on a sabbatical program in the UK, working in the environment of Penrose and Louis Wolff and that distinguished group. And so Bickel developed a diet using casein hydrolysate. It was really quite easy to do a simple diet free of phenylalanine because aromatic amino acids stick on to activated charcoal. So you could remove aromatic amino acids out of a protein hydrolysate and get a diet that had protein, and you could add back the other amino acids. They treated a 26-month-old girl who had a phenylalanine concentration of 67. That's very high, I might point out. This was clearly a very classic patient. This patient clearly improved. Their ferric chloride became negative, and over 6 months, the eyes were brighter, the interest in surrounding, child learned to crawl and all those things. And then they resumed the old diet, and the patient went back to her previous ways, in other words, marked deterioration. Their publication, it was published in 1951, concluded that it seemed to be very beneficial. Further trials were needed, but they said the problem was this child's 26 months old, and so that substantial damage had obviously occurred. So what you needed was a test that would identify a child before that, in other words, so you could treat from early infancy to get a much better outcome. So obviously that background, it was the precipitating thing of the need of having a simple test that you could apply to the whole healthy, quote, baby population of babies to see if they had phenylalanine elevation at birth. And that's where the action moved to Buffalo, New York, and Bob Guthrie at that time, a pediatrician who was formerly trained in microbiology, was working at the State University there. And Bob had a developmentally delayed child, not phenylketonuria, but a child of his own, and was active in the local organization, advocacy organization of persons with developmental delay. And so they went to Bob and said, you know, with using your microbiologic techniques that you're using looking at nutritional aspects of cancer, could you develop a simple test for picking up phenylalanine in healthy babies that would be cheap, that you could apply to the whole population? And so he took that test, that question, the task, and developed a test that technology is still used today in some way. In other words, he came up with the idea of putting dried blood on filter paper, as shown here. This is a very old sample from Hopkins that's more than 50 years old. But the point is, you just simply spot paper with blood, and you use that to do the test that he developed. Now, we use the same technology today of dried blood spot on more sophisticated collection technology. But anyway, here's Bob looking at a plate that he was using, and this is a Pyrex dish that he had agar in there in which bacterial spores were embedded, and the spores that he had was a strain of bugs that required phenylalanine for growth. And so he could jiggle the conditions in such a way that if he put a punched spot out of a piece of paper in here, you don't see anything happening here, right? But if you look at this spot right here, you can see that there's growth around there. And what's happened, the phenylalanine in that spot was sufficiently elevated that when it diffused out into the agar, it precipitated growth. And so he came up with this idea of the bacterial inhibition assay. It was able, this was a semi-quantitative test at best, but you could jiggle the conditions so that the size of the area of growth gave you some indication of the elevation of the phenylalanine. I had one of the advantages of being around forever is I happened to be around at that time running the metabolic clinic at Hopkins, and I thought there's no way in the world this is going to work because it was so simple, right? But it just seemed, I mean, how could you Pyrex dish and so forth? But anyway, the bottom line was it worked, and it worked pretty darn well. And so it was then possible to identify these children early in the newborn period, and that happened, and then put them on a diet that was restricted in phenylalanine. And of course, when this first started and the screening was started, you know, there was a lot that was not known, in other words. But the point is that diets were developed and many babies around the country were treated. This is a very old slide from that same time period with 43 children identified in the newborn period who were put on a diet. And you can see this is a very different pattern of ability. You can see that the overall intellectual ability has shifted toward normal, and with improvements in the dietary management and so forth, the average intelligence of a treated person with PKU today is basically normal. Now, there are many other issues that we won't go into, but it's dramatic. So it spread around the country amazingly. Here you had a condition with profound developmental delay, you identified early, and you could treat them. And this thing became such a big deal that the states across the country started screening immediately, because you had a treatment for developmental delay, which was just incredible. And so what happened was the following. Newborn screening, I might point out, was placed in the public health departments at that time because it was felt that everybody should have access to this, and this should be a public health issue. And today, in all states, newborn screening is under the auspices of the state health department, and that remains today. It's quite unusual to have a medical program of this nature based in the public health department, but it's been important. Routine screening was expanded and begun really, it was eventually in all 50 states by the early 70s. Now, the thing is, this worked really well, and conditions such as PKU was obviously the target of the testing. However, it's perfectly clear that you would say, well, gosh, since this is working for PKU, why can't I add another condition? And so that happened. The most common one that was added early was hypothyroidism. And then on a state-by-state basis, people added a variety of things. And I might point out there were things added that eventually proved out not to be a disease. But the point is, states were adding things across the country. This became a big deal because there was no systematic evaluation, et cetera, tremendous variation, and when people moved around the country, it was a real problem for families who had a child with one condition, and then they moved, and the state was not screening, and the mother was pregnant, et cetera, so it was a big problem. And I like to point out is that, I stick this in at the end of this slide, is that we currently screen a little over 4 million babies for over 30 conditions today. And I might point out, newborn screening is by far the most common form of genetic testing that's done. So keep that in mind as long as you would like. Now, this became such a problem that it made the press. This is an article from the Examiner, which is a Washington, D.C. Paper that they hand out when you get on the metro in Washington. And so forth. And the thing is, it became a big issue here because Washington, you live in Northern Virginia, you have one screening program, you drive 2 or 3 miles into D.C., you have another screening program, you drive a couple more miles and you're in Maryland, and there's a third program. So it became the little teeny Washington, D.C. between two big states made it. So the point is it became a big issue. Maternal and Child Health Bureau in 2001 awarded a contract to the American College of Medical Genetics to produce medical and scientific information related to what conditions should really be on the panel. The college brought together an expert group of 70 people who worked for about 2 years. They were physicians, scientists, consumers, laboratory folks, lawyers, ethicists, all sorts of folks, and worked on this. And they came out, and then once they came out with recommendations, it was reviewed by another independent panel, and then they published their results. And it was published as a supplement to Genetics in Medicine, as shown here. And this is an interesting, for those interested in newborn screening, this is about a 250-page book on newborn screening, but it's very interesting to read about it. But fundamentally, they came up with a series of criteria for this, quote, uniform panel, and the term that was used for it is the Recommended Uniform Panel, or RUSP, and we use that term today. And there were a variety of things on it. The condition had to be identifiable at birth. It had to be a big problem. A burden of disease was big. You had to have a test, obviously, that was reliable and that didn't miss anybody but didn't have a lot of false positives. You had to have a treatment available. None of the conditions on the panel, nor recommended today, are there because unless they have a treatment. The cost of treatment was discussed, not too seriously, I might point out, but it came up, and et cetera. So that was and I might point out the criteria for a panel here is far better than the old recommendations that came out of the World Health Organization 50 years ago. This panel recommended 29 conditions on their so-called core panel, all of which had serious medical complications, and all the children benefited from early diagnosis and treatment. In that original core panel, 20 were disorders of amino acids, fatty acids, and organic acids, and those were all detected by tandem mass spectroscopy. And that technology really is the underpinning of our ability to do newborn screening today with all the conditions. Tandem mass spectroscopy is critical for that. There was 3 hemoglobinopathies on the original recommendation, and then other conditions that were not developed, you couldn't test with these technologies, such as biotinidase, CF, galactosemia, and disorders of hearing. At about the same time, the United States Congress was working on the Healthy Act of 2000. It took quite a while to get through, and within that, there was a specific part of the law that demanded the building of a federal committee that would advise the Secretary of Health and Human Services about what should be on the newborn screening panel. And this is an interesting and lengthy law that we don't have time to go into, but it's important. Some of the things in that law, and it's now in its 3rd iteration, points out that all the recommendations that come out of this committee must be evidence-based, they must be peer-reviewed, and have a significant impact on public health for all newborn screening. The title of this bill, the federal bill, and I might point out, is this bill is passed by the United States House of Representatives, the Senate, and signed by the President. But the current bill, the title of it, is Newborn Screening Saves Lives, which is correct, we think. This committee met for the first time as the college was publishing its book. And so the committee spent a long time looking at the ACMG report and eventually unanimously accepted the report and made a recommendation to Health and Human Services that it was that this was the recommendation of this group. The Secretary in time accepted the recommendation. The Secretary moved slowly, shall we say, but accepted the recommendation, but importantly designated the uniform panel as the national standard for newborn screening programs in the United States. That has a lot of implications that I'd be pleased to talk with you about afterward. This committee, once they made the recommendation, was the only time I think that newborn screening will make the front page of the New York Times. But it was considered, as you can see here, the recommendation that that the federal government was making that all babies be screened for 29 conditions was a big deal. And there was a whole page inside the New York Times describing all the background for this. And it was written by Gina Collada, who I think is probably historically the premier health reporter for the Times. This committee developed a very formal mechanism to nominate conditions. Anybody can nominate a condition to the committee, but the form is set. You have to have an accurate description of the condition. You have to have a good screening test, and you have to describe that carefully. You have to have a really well-established treatment, and then you obviously have to have references. The nominated condition has to be very serious. It helps tremendously to have prospective pilot data from the government. You need to have a good idea of what the disorder looks like, and there's a screening test that will identify this condition reliably. If the spectrum of the disease is broad, you need to identify those people who would benefit most from treatment, and their defined treatment protocols. And if a drug is being used, the drug has to be FDA approved. Since this committee began in a little over 15 years ago, they've considered 16 nominations, and these nominations first go to the chair, then they go to an evidence review. The evidence review that the committee uses is very sophisticated, and it costs a lot of money. A single evidence review costs about $100,000 to do. So a recommendation that comes to the committee doesn't get sent for evidence review unless it looks like it's really a good, solid recommendation. Since the committee has recommended that Pompe disease, SCID, severe cyanotic congenital heart disease, X-linked leukodystrophy, and MPS I be added to the recommended uniform panel as of today. At the current time, the committee has recently received, in March of last year, received SMA. It's the second time SMA was nominated. It received SMA. It's been sent for evidence review, and there have been 2 preliminary reports of evidence, and the committee is meeting as we sit here today, and they will be considering this. So it's possible that during the course of this meeting we will have a decision from the committee on SMA, and if I were Jimmy the Greek, I would certainly bet that it will be added. It should be added anyway. Now, what's driving such interest? I mean, why is this happening? It's always been technologically driven from even the little dried blood spots. So the ability to use tandem mass spectroscopy to identify important diseases is critical to the whole thing. But in addition to the technology, the extraordinary efforts of advocacy groups has caused a dramatic increase in the number of conditions that are being screened. And I like to cite that the field has had many advocates over the years, and it's had very famous advocates. For instance, Pearl Buck, who was the first woman in the United States who received the Nobel Prize for literature, had a child with phenylketonuria. And the child was obviously born in China, where Pearl lived, long before PKU was defined and so forth, but the child in later life was shown to have PKU at a time when JFK was president, and Pearl Buck had the opportunity to have the ear of the president. So you've had advocates at that level, but the Mississippi advocacy story is one of my favorites. In 2000, a 2.5-year-old perfectly healthy boy in a small town died suddenly. He was the mother, who was extremely bright and so forth, was, why in the world this perfectly healthy 2.5-year-old boy? And so she had a metabolic autopsy done, which is a very important thing. A metabolic autopsy is obviously taking material after the patient is died, and do biochemical studies. And she actually collected material and sent to the Mayo Clinic, and they decided it was clear that this boy had suffered from medium-chain acyl-CoA dehydrogenase deficiency, or MCAD deficiency, one of the conditions on the panel. His name was Ben Haygood. Now, the mother was also told that had they known that this boy had that, they could have had simple dietary instructions, and this would have never happened. And so she thought that was not a good thing to do, and so she took it upon herself to go to the Mississippi legislature. And she got a few concessions the first time she went, but she went back. And the second time she was passed was the Ben Haygood Act, which still is present in Mississippi. And this is Mrs. Haygood here with her family. These are her children and her husband, and this is the governor of Mississippi. And fundamentally, the law, Mississippi, like most states, doesn't have much money, and so they basically came up with a plan to expand the newborn screening program, and they would build the places that submitted samples, et cetera, and do that, and they also set up things around the state. So the point is that Mississippi has an outstanding newborn screening program, all funded in addition, in response to Mrs. Haygood's really fine work there. One of the questions that comes up is that do adding conditions to the RUSP make a difference? Does it make any difference when we do this? And the answer is yes. There's a lot of evidence, but there's a very recent publication on cyanotic congenital heart disease, which is one of the more recent conditions that's been added to the panel. A group comprised, including Scott Gross from the CDC, has done a very careful analysis of early infant cardiac deaths in the states that had added severe congenital heart disease screening, cyanotic heart disease, and those who had not. And they demonstrated that there was a 33.4% reduction in deaths from congenital heart disease in those states. That's very impressive and so forth. Now, I'd like to finish my comments with just a few things of some of the challenges that we're doing. There's been a huge amount of discussion and legal action about the retention and use of residual dried blood spots collected at birth. These dried blood spots are truly invaluable because you can go back when a patient has a condition later, and if you don't have it, you can go back and do additional studies. They're invaluable in setting up new tests in the state laboratories so that you will have thousands of anonymized samples to do. But some folks are extremely concerned about the government having a blood sample that has your DNA. And I think that I've never completely understood that, but that's a big problem. The other thing is that the second other thing is that that as we're expanding newborn screening, some of the new technologies and treatments that we're using require specific mutation analysis. For example, one of the conditions on the horizon will be adding Duchenne muscular dystrophy, and in that condition, the use of the antisense oligonucleotides in Duchenne requires a specific mutation analysis. So that would be a big deal. The other thing is, how in the world do we follow and treat the many late onset patients that we're seeing? In other words, in the lysosomal storage diseases, as you've heard and as you know, many of the patients you identified may not have symptoms for years or decades. And how are we going to follow them, and how are we going to treat them in that time? The extraordinary cost of some of the new treatments. When we had 2 or 3 new treatments that were expensive, it was not a big problem, but now it's becoming a big problem. The other thing is that I like to point out that you never really understand any disease until you screen the general population. And anytime you add anything to the newborn screening panel, you're going to find things that you did not understand. You will find that, for example, had you asked us about Pompe disease a couple of decades ago, we would have told you about the acute infantile Pompe that was described by Johannes Pompe in 1931. But we now understand that most of the patients that we're picking up, the majority of the patients we're picking up in the newborn period with Pompe are late onset. Newborn screening is also a huge catalyst for study and research in rare diseases, for new therapies, and so forth, and so that's a very important thing. So anyway, we could talk all day. I could talk all day about newborn screening, but that's all I have to say, so thank you very much for your attention.